Okay, the recording is in progress. So if you're just now joining us, we're going to give people a couple of minutes to pop in. I see our participants number is rising, and we'll get started in a moment. Thanks for being here. Should have put some hold music on or something. It's too quiet. We wait.
Yeah. You think just give it till 11:05, Blair, just to.
Yeah, we'll give it 3 minutes, let folks join, and then we'll get going.
Can people already hear us and see us?
Yeah, why don't we, I'm gonna open the chat box to everyone. If anyone's having issues or can't see or hear us, can you let us know, or you can give us a thumbs up? All right, I'm gonna go ahead and get started because I'm excited, even though it's 3 minutes after the hour, not 5. And we've got a good group of folks who've already joined. So just to introduce myself, say hello, then we'll go through some housekeeping, some more introductions, and then we'll get to what everyone is here for, which is to hear from Dr. Terry Derks about Empagliflozin treatment in GSD1b. Before we get there, my name is Blair Stone Schneider, and I'm the executive director of the Sophie's Hope Foundation Cure GSD1b. I'm actually also a mom to a GSD1b kid who's 15. This is the first of our webinar series. This series has been in the works for about a year in planning, and we're really excited about it. We think that it's going to be a great opportunity to bring together patients and caregivers from all over the world, as well as providers, and build our global network to improve lives of patients with GSD1b and their families. A few housekeeping things. Interpretation is available today in both Spanish and Portuguese. If you look down in your bar at the bottom, you'll see a globe icon. And that globe icon, you'll need to click on that, and then you select your language. And then you'll be put into either an English, a Spanish, or a Portuguese channel. And you will be hearing that interpretation based on the language that you select. I'm also going to put that in the chat in all 3 languages, in case anyone is not sure how that works. So that's there also. This recording, or this Zoom, is actually being recorded. It will be placed on the Sophie's Hope Foundation YouTube channel, and will also be on the Cure GSD1b website, so you can look back to it later if you missed something, or if you need it for reference, or you can share it with others. And if you were not able to attend live, you'll be able to watch it then later as well. Just a little bit on the format of our webinar. For this format, and this is part of the design, we decided to take questions in advance so that we could then give those questions to our presenters, and that they could then more or less tailor their presentation to what it is that GSD patients and caregivers and providers might want to know. It also gives them time to be thorough and thoughtful in how they answer. So we're super lucky to have someone like Dr. Derks here tonight who is willing to take the time to do that. And he spent a tremendous amount of time providing really amazing answers to the questions that were submitted. We had a lot of amazing questions. And you'll probably see some of yours reflected. We tried to group questions in terms of topic and keep them general so that they're applicable to as many patients as possible. And it's possible at the end we might take additional questions and question and answers if more come up. We'll just see how we're doing on time there. Before we introduce Dr. Derks, I also want to introduce two other super important people, and those are Jameis and Margot Lafreniere. The Lafrenières are the founders of Sophie's Hope Foundation. I won't talk much about the foundation. I'll let Jameis do that, but we're super grateful for all they've done for the 1B community, and especially for helping us fund and organize the webinar. So I'm going to hand it over to you, Jameis.
All right, thank you. And I'm going to try really hard not to be redundant because you hit on a lot of good points there. So again, for everybody, welcome. This is our first GSD1b Ask the Expert webinar. I think as Blair mentioned, the goal would be to do these quarterly, you know, and find the right topics and the right presenters. So we're lucky we've built a really great network really across the world of people willing to help us, including Dr. Derks. So I'm Jameis. I don't know if you can see Margot the way the Zoom screen works.
Oh, you muted yourself. There you go.
Yeah, we are the parents of Sophie, and that's the inspiration for Sophie's Hope Foundation. She's a first grader with GSD1b. We started the foundation. Many of you I saw that have joined are pretty well aware back in 2020. And our mission is and always will be to develop a cure for GSD1b. But I think what we've learned over these last 4 years is just how beneficial education, access to information, and being part of a strong and well-educated community has been for us, but also we've seen it benefit GSD1b patients and families all across the world, especially where potentially information is more difficult to get. So that's been the inspiration for kind of a lot of the changes and a lot of the new education that folks have seen out there. And for years, we've been, or me and Margot have talked about trying to do a webinar, and we just didn't have the bandwidth to do it. So special shout out to Blair for taking this idea and really turning it into action. So I think these are going to be great. I'm really excited for them. And I do want to spend a minute or two talking about Dr. Terry Derks. So that does bring us to today's topic and guest. And we are extremely honored and excited to welcome Dr. Terry Derks, although he does tell me to just call him Terry, but I can't do it. So Dr. Derks, as our expert for today's discussion on Empa treatment for GSD1b. Dr. Derks, who conducts research and treats GSD patients at the University Medical Center in Groningen, in the Netherlands, is not only a leading expert on GSD1b, but one of the first supporters for Sophie's Hope Foundation. In fact, Dr. Derks was the first person that I reached out to personally for help, and was the first person that I asked to join our scientific and medical advisory board. And he graciously had accepted several years ago. So everything he does for us is on a volunteer basis, and we appreciate it so much. He's been an incredible research. So thank you, Terry Derks, for your years of service to the GSD1b community and for helping us kick off the Ask the Expert webinar series. I noticed in the attendees that Maria Vega de Cunha has joined as well. So I think the entire GSD1b community always, anytime we can thank Maria for the work that she's done, and there are other doctors involved as well, but Maria, thank you for always being involved and helping and kind of pushing the envelope for us. So thanks for joining. So with that, I thank everybody for joining. We look forward to doing more of these, and I'll turn it over to Blair to get this one going.
All right, I think everybody is probably tired of hearing us talking and wants to hear Dr. Derks now, so we'll be quiet. Dr. Derks, feel free to go ahead and share your screen.
Everybody should be able to see the screen now. Is that correct?
Yeah. Yep.
Okay, cool. Let's get started then. Thank you very much, Blair, James, for the very kind introduction. I also saw Maria coming in the meeting, and it's really wonderful what she has done in the past years. And without her, we wouldn't have had this webinar today. I hope that in these 90 minutes, I'm able to give you an overview of the 5 years of experience with Empagliflozin or Jardiance in GSD1b. And yeah, let's see if we can answer at least the first 38 questions and the next ones that will come up. I think September in particular is a very good month for webinars in relation to GSD1b. The first webinar that I was part of surrounding the topic of GSD1b and empagliflozin was in September 2020. And at that time, together with Saskia and with Saskia Wortmann from Salzburg and with Sarah Grünert from Freiburg, we were sharing the first experiences with the treatments in GSD1b patients. And then 1 year later, we repeated that. So that was September 2021. Everybody was bored of looking at screens, but we really had good attendance at that time during the COVID pandemic while we were organizing these webinars. And now we are 3 years further, and I'm really thrilled with all the progress that has been booked since then. So in relation to this topic, I have nothing to disclose, but I would like to emphasize the purpose of this meeting. I think it's important to mention that I'm trying to provide general information based on the experience that we have. And it is, of course, thanks to a lot of colleagues that in collaboration again generated this knowledge and experience, colleagues, but also patient representatives. I think most of the knowledge is accessible online. So you can take that knowledge back in discussions with your healthcare providers and see if this is helpful to improve the situation back home. And I'm not intending to present and to allow people to use this for certain self-treatments. It's really meant to help you in your discussions with your local healthcare providers. And if needed, people like Maria and I, my colleagues, are always findable to see if we can help in the best possible way. Having said that, I would like to kick off. As I mentioned already before, without the fundamental research that was performed in the De Duve Institute by Emile van Schafting and Maria Vea de Cunha, we would not have this webinar today. And this is really the breakthrough scientific paper in which they described the new insights in the disease mechanism of the neutrophil dysfunction and the neutropenia in GSD1b. And in a little bit more detail, they identified a chemical compound called 1,5-AG, anhydroglycitol, which is not properly metabolized by the neutrophils. And that does allow, and that's the reason why these neutrophils can't function, can't grow, cannot multiply. So there is neutropenia and there is neutrophil dysfunction. And the idea they postulated was that by the use of a class of drugs that were originally prescribed to patients with diabetes, which sounds counterintuitive because diabetes is a disorder where high glucose concentrations are the case, whereas in GSD1b, obviously, we are dealing with hypoglycemia. But nevertheless, they postulated and also provided first insights towards the treatment with this class of drugs called SGLT2 inhibitors to the treatment of the neutropenia and neutrophil dysfunction related symptoms in GSD1b. And the mostly used example within this class of drugs is empagliflozin, what we are talking about today. The general idea is that with the use of empagliflozin, there will be glucose, the glucose reabsorption in the kidneys will not take place enough. So there will be glucosuria, glucose in the urine, which is attracting extra water. And by that also the compound, which is toxic for the neutrophils, which is pretty similar biochemically to glucose, will be excreted, and the lower levels will cause a better environment for the neutrophils to further develop. So after these fascinating findings, there were several steps made by different doctors. This paper was discussed, or the paper was discussed by doctors who were struggling in the treatment with their GSD1b patients. And I remember that I was calling with Saskia Wortmann when I was sitting in the train, and she was calling from Salzburg discussing one of our patients. And in the end, we raised the idea of perhaps we should go for it and start with an SGLT2 inhibitor. Well, some people may follow the clinical trials for gene therapy or messenger RNA therapy for GSD1a, and these trials, they take years and years, they take decades. So one strategy that we came up with was the off-label prescription of empagliflozin. So in that way, you do not necessarily have to do a formal clinical trial, but if the idea is good and if you fulfill certain requirements, it is possible to follow these professional guidelines, as many countries have them. In our country, they're according to the Royal Medical Association, which is abbreviated as KNMG. And if you follow these rules, it is possible to off-label prescribe medications like empagliflozin. So that's what we did. And in parallel, of course, we asked the insurance companies from our individual patients if they would be willing to cover this treatment. And unfortunately, they all refused. That didn't withdraw us from starting this treatment, and we followed a protocol that we designed as a team. And that team was Saskia Wortmann together with Johan van Halve, and also with the support of Maria Veder Cunha and Emil van Schaftingen. We described the first observations in the GSD1b patients that were treated. And that was published almost 2 years later in August 2020. And in the right upper panel of this slide, you can see the concentrations of the chemical compound that I was referring to earlier in my presentation. And you see them nicely drop within 10 to 14 days to newer levels in the first 4 patients who were treated with empagliflozin at that time. We wanted to expand this knowledge and share it as much as possible. So we presented this at the International GSD Conference in November 2019, and that was shortly before the COVID pandemic hit, here depicted in the time axis in green. And also thanks to the webinars that we presented, nowadays, we have at least over 20 scientific papers about different observations made in the treatment of GSD1b patients with empagliflozin and other SGLT2 inhibitors. And also with the support of the Sophie's Hope Foundation, we formulated treatment recommendations. In particular, in our center, we also addressed the treatment following certain value-based healthcare principles, by which we were also able to do economic evaluations, by which finally we were able to convince the national health authorities. We wrote a formal application in November 2022 for the reimbursement of this treatment, which is actually cost saving. It is saving hundreds of thousands of euros per year in our small country by changing the medications from the, well, formerly used Neupogen or GCSF for the much cheaper Empagliflozin. So our national authorities, they took almost 2 years, but very recently they have approved the drug and the formal reimbursement of this treatment, which took really a long time, which was quite a headache-causing experience. In parallel with that and with all the publications, we also submitted the file to our online repository for pediatric drugs. In Dutch, it is called Kinderformularium. All the treating physicians can access that. And now the empagliflozin is officially added to the list of medications for this indication, the Glycogen Storage Disease type 1b. But at the end of my presentation, I will also demonstrate to you that there is another ultra-rare GSD subtype for which empagliflozin also might be useful. And both indications are now in this repository. The nice thing is that there is an equivalent in German and also one in Austria. And hopefully once there will be a European one or a worldwide version, because that would be a very logical thing to do. So the Kinderformularium, this repository, is one of the major sources of information that I'm using for the rest of my presentation. And this is just a few of the many publications that came out since the first descriptions by the group from the DUVE. So here you see a paper where we summarize the first efficacy and safety experiences in 112 patients with GSD1b. We also studied the patient-reported outcomes in these treatments. We looked in more detail not only to the value for doctors and for families, but also to the cost savings that were made to convince authorities even more. There are treatment recommendations that were written up recently. And as we progressed and new children were diagnosed pretty early, of course, also the experiences increased with the treatment of very young children with GSD1b and the treatment with empagliflozin. And I will come back to that topic based on the questions that have been raised as well. So these are all useful resources to refer to or to read yourself or to refer to in discussions with your local healthcare providers. There's also very nice information on the websites of the FDA and the EMA, and of course also from the producer of the drug itself. So all information about side effects and what has been experienced in the past is accessible through these sources, and I've used them to generate the rest of this presentation. I could not do that without the support of Blair. So Blair, she nicely listed and categorized the questions that came from the group in different categories. And before I start with the first 6 general questions, perhaps I should ask Blair if I simply can continue or should I wait for a while? Are there already questions? What should I do?
Oh, keep going. You're doing great.
Keep going.
Yeah.
Okay. Good. So these were the first questions, Blair, that you selected for me. Are there any contraindications to use Jardiance in 1b patients? What are the pros and the cons of using Empa? Is it okay to take empagliflozin in pregnant and breastfeeding patients with 1b? Can Empa be made into a liquid or mixed with food for children who cannot swallow pills? Can patients stay on Empa for many years? Will it become less effective, or will they build up tolerance to it over time? And is there a replacement for Empa in the event of a shortage? So let's go to the first questions. Are there any contraindications to using Jardiance in 1b patients? The short answer is yes. And according to the drug information as provided by the company, by the producer, it is hypersensitivity and dialysis. But how can somebody know whether he or she is hypersensitive or whether his son or daughter is hypersensitive to the drug without ever trying this? So this is, of course, a very difficult topic. I can imagine that people would try the drug once the indication is made and then find out whether it is truly a big risk or whether it is more a theoretical consideration. The second contraindication, that is an important one to keep in mind. It refers to the treatment. Dialysis is the kidney replacing therapy that is performed for end-stage kidney disease. And it is important to keep this in mind because also in GSD1b, in theory, and also in the elderly patients, it is more common that end-stage kidney disease may develop. So in dosing the drug, this is something to consider. These are the two major contraindications. Then coming to the next questions, what are the pros and the cons of using Empa? And the way I would look at it is, what are the alternatives? So back in time, there have been decades where nothing was available. So patients were suffering from bacterial infections. They had difficulties with the dietary treatment because they had inflammatory bowel disease from the upper part of the gastrointestinal tract until the last part. So until the introduction of GCSF, Repurposing, there was nothing else available. So GCSF has been a breakthrough, has improved the situation for many patients, but obviously it was not a perfect solution. The disadvantages of GCSF are numerous. These are painful injections. The side effects became clearer and clearer, which includes the organomegalies, also the malignancies. They are extremely expensive also, these medications. And also from a practical point of view, it is difficult to maintain the treatment while people are, for instance, traveling, because the syringes need to be kept at low temperature, which means that if you go on holidays or if you're traveling, you have to carry a box with this medication. So all disadvantages, and most of all, it is not a perfect treatment in terms of efficacy. So the cons of one therapy may become the pros for empagliflozin in this respect, because empagliflozin, it's not hurting. These are just pills that you can swallow, or you can mix it with the food. The side effects are mostly described for patients who are on this drug, patients who have diabetes, who also use insulin. So, and these are elderly people. So the whole spectrum of side effects needs to be reconsidered, of course, taking into account what has happened in the past, what we have learned from this different cohort with diabetes patients, but it may be something different for the patients with GSD1b, and I will come back to that. Other disadvantages of GCSF, which are a pro for the use of empagliflozin, are of course the costs, and it is very practical to carry these drugs with you when you're on holidays. So there are a lot of considerations in terms of what you would call pros and cons. It's a balance between efficacy and safety. I will come back to these topics later in the presentation, where more specific questions related to this balance have been asked. But in this paper that we published earlier this year, we included a very systematic benefit-risk assessment that can generally be performed for the off-label use of medication, and we apply that to the situation of empagliflozin in GSD1b. Then the next question, is it okay to take empagliflozin in pregnant and breastfeeding patients with GSD1b? That is a very difficult question. The use of empagliflozin in pregnancy and in GSD has been used until now in 1 GSD1b patients during pregnancy with good success, and that paper is also accessible. There were no obvious adverse effects. There's also knowledge on this drug derived from animal studies. And a recent systematic literature overview on the children born, or the pups born out of these animals, allowed us to gain a little bit more information about the effects of SGLT2 inhibitors during pregnancy and lactation. And it was found that it is generally safe during the first trimester. However, exposure during, and now we have to translate what was found in rats to the situation in humans. That suggested that in the late second and the third trimester of human renal development, SGLT2 inhibitors may cause damage to the kidneys. And that's the reason, that's one reason why doctors are cautious and reluctant and would not advise to use these drugs during pregnancy and breastfeeding. There were also studies showing an increase in miscarriages and congenital malformations. Animal studies have shown that the SGLT2 inhibitors were excreted in the breast milk, and they can affect the growth of the newborns. But again, all data from animal studies, and not a lot of information based on human studies. And that's explainable because most of the patients who are in need of these drugs used to be patients who were beyond the age of becoming pregnant and breastfeeding. But based on these findings, it is advised to consider to discontinue the SGLT2 inhibitors during pregnancy and lactation. On the other hand, the situation in the paper where one patient was described with GSD1b and the use of empagliflozin during the pregnancy, it shows that there may be exceptions to the rule. Then the following question, can Empa be made into a liquid or mixed with food for children who cannot swallow pills? The short answer is yes. I would advise to ask your doctor to discuss this with your hospital pharmacist, which is the most straightforward approach. In the guideline publication that I mentioned earlier, there is a nice description how that could be done, but hospital pharmacists are also capable and used to exchange these standard operating procedures to make these formulation, to make capsules or to make solutions, so whatever is preferred. In general, hospital pharmacists would prefer to make personalized capsules with alternative amounts of milligrams of empagliflozin, rather than making the liquid formulations, because the liquid formulations, they have the uncertainty of the stability. And then it may become impractical again, where in practice, the capsules, once they are made by the hospital pharmacist, they are considered stable enough. So my basic advice would be to discuss this with your doctor, and based on the dosing regimen, it may be practical to ask the hospital pharmacist to make capsules on a personalized base. Because the difficulty is that for empagliflozin, there are only 2 tablets available, and these are the 10 milligrams tablets and 25 milligrams tablets. I will come back to that later too. So many of these questions, of course, they partially overlap with each other or have related topics to be discussed. Then the next question was, in this section, can patients stay on Empa for many years? Will it become less effective, or will they build up a tolerance to it over time? I think patients can stay on Empa for many years, but we do not have decades of experience with large groups of patients. And if we have them, they are with diabetes patients, of course, who are older. But there's no reason to believe why Empa will become less effective over time. But on the other hand, as time progressed, we also observed that some of the GSD1b patients may anyway develop inflammatory bowel disease exacerbations. So the effectivity of the treatment is not 100%. And I don't think it has something to do with tolerance, but as we were starting to treat the patients, the observations that we made were also again reasons to go back to more fundamental studies in the laboratory that shed a new light on how the drug is actually working, and how the differences in treatment response might be explained when studying different patients in a bigger group. But the last question is a very relevant one. It's also really a question that is popping up on many moments nowadays, because it's a general problem, shortage of medication, and it may sometimes relate to medication that is taken for granted by many people because it is really commonly used. But as the amount of producers is becoming less, I think it is in particular a risk for drugs who are not patented anymore, or where there is not really a big business case. So is there a replacement in the event of a shortage? Yes, maybe, probably. In the group of SGLT2 inhibitors, there are a few others that are FDA approved for managing adult patients with type 2 diabetes to improve blood sugar control. So these are several of the options that could be considered under these circumstances. But I hope that it is not a very relevant question on the short term, but nobody knows exactly how to predict this topic because it's very difficult. Drug supply, medication supply in general. So let's go to the second group of questions, and they were dealing with the questions how to initiate the treatment with empagliflozin. So these were the questions. So I would like to start with question number 7. Is there a level of neutrophils or lymphocyte counts required to start treatment? And I think the answer is no. Going to the next question. How early can children start empagliflozin? We have learned in the last years that we can start at a very young age. So in this paper where the observations were shared with the treatment in 21 infants with Glycogen Storage Disease type 1b, we have demonstrated that the median age of starting the treatment was 3 months. And in some children, it was already started in the first month of life. There's some important considerations, in particular in younger children with GSD1b. Well, most and for all, they are diagnosed at a very young age, but in particular when children are very young, let's say in the first years of life, they have a higher hypoglycemia risk for several reasons. That's how biology is organized. They have a higher requirement for carbohydrates in general. They're not capable of expressing their symptoms and signs. They're not capable of walking to their parents when they become low. So several risks. And that's one of the reasons why I think that while trying out this treatment or while initiating the treatment, I think it is wise to do regular glucose checks. And probably it's better to do this under the control of continuous glucose monitoring. Another consideration for very young children is the fact that empagliflozin breakdown is slower. So the liver is not mature yet. So it takes more time to metabolize the same amounts of empagliflozin compared to adults. And that's why it's probably better to start off with a lower dose and to adapt the dose depending on the safety and the efficacy that is observed in the individual patient. Two questions that relate to each other are, should patients start with empagliflozin at the diagnosis, even if there are no signs of neutropenia or IBD yet? And what are the tests necessary to determine neutropenia and start empagliflozin treatment? And that's also a very nicely described section in the treatment recommendations paper that has recently been published. And I summarized it here at the right panel of this slide. We generally recommend to start empagliflozin in all genetically confirmed GSD1b patients. If there are any signs of neutropenia or neutrophil dysfunction, we consider it the first line of treatment instead of GCSF, for instance. Sometimes there is a family history why they might become, why it is suspected that they may become symptomatic. And it's also a consideration to start this treatment if there is surgery expected where wound healing has to take place. On the other hand, it is sometimes quite difficult in the beginning to recognize the signs of neutropenia or neutrophil dysfunction. Obviously, you can measure the neutrophil numbers, but there's also a group of patients with GSD1b who have low numbers, low neutrophil counts, but do not really have a lot of problems with their IBD, with infections, or for instance, mouth lesions. On the other hand, sometimes in young children, it is difficult to recognize the first symptoms of IBD because it can be like diarrhea or malabsorption, needing more carbohydrates than one would expect based on the treatments in other GSD1b patients. So sometimes these are quite subtle symptoms. So it of course, in the end, it needs to be individualized. I'm not saying that every patient should start with empagliflozin, but I think once symptoms are recognized or expected, it is better to start with empagliflozin as a first line of treatment rather than starting with Neupogen. And what tests are then needed to do this? Yeah, that was the previous question number 10. It also relates to the question, should patients test for 1,5 Ag levels to see if the Empa is working? And on this slide, you can see some of the tests that can be performed to systematically check whether the treatment is effective. And we also recommend that if available, a 1,5 Ag is monitored in the patients. And well, now methods are available to measure this compound in dry blood spots. So these are filter paper cards that can be sent over mail. Excuse me. So it is. It should be relatively easy, and I expect that these tests will become available more and more. I have a cough. I need to drink something. Then I come back.
No problem. Take your time. So while Dr. Derks is getting a drink of water, I just want to make sure that everyone is aware that there is a chat box for the webinar. If you do find yourself having questions as the webinar is going on, I can't promise that we'll get to many questions, but please feel free to put them in the chat box. That is where we will look through and potentially have follow-up answers if we have the time. So please use the chat box.
Apologies.
No problem.
Can you see my slide again?
Yep.
Yeah. I'm having a cold, and I was hoping that it would not happen, but I really have this itchy thing in my throat.
Oh,
Well,
sorry to hear it. Take all the time you need.
yes, thank you. So these are the parameters that can be used in the assessment of the treatment efficacy, and it's a long list of things that could be measured, and that includes also 1,5 Ag. And I'm expecting that in the upcoming years, this testing will become available also in the clinical laboratories, where nowadays it is mostly a research test. So we're now moving to the topic of dosing. These were the questions asked. It is relating to the average dose of Empa for adult patients. Should the Empa doses get larger as children grow, or does it depend on symptoms and blood counts? What are the steps in finding the right dose of Jardiance? Should Empa dose be adjusted during pregnancy or while breastfeeding? How long do I stay on a Jardiance dose before making an adjustment? Well, we have dealt already with this question number 5, which relates to question 3 on the previous slides, because it's not okay to take empagliflozin during pregnancy or breastfeeding. That's the general statement. Exceptions should be made on the individual base. Then the other questions about dosing, they also relate to the balance between efficacy and safety or side effects. And the general approach has been made that the starting point was the knowledge in the treatment of diabetes patients. So in type 2 diabetes, An initial dose of 10 milligrams of empagliflozin once daily is recommended for the monotherapy or the combination therapy. Sometimes the type 2 diabetes patients use a combination of drugs. And the maximum daily dose recommended is 25 milligrams. In individuals with heart failure, which is another indication for of empagliflozin, a dose of 10 milligrams once daily is recommended. So exceptions are patients who have kidney dysfunction. Then based on their kidney functions, the dose needs to be adapted. And these general rules that are applied in diabetes likely also apply to GSD1b. And also the questions about renal impairment, they also may be applicable to older GSD1b patients. So then, based on these known doses and appreciating the fact that it sounds counterintuitive to give a drug that is lowering glucose concentrations for patients with GSD1b who already are at risk of hypoglycemias, it made sense that doctors approached this very carefully, starting with the lower doses and trying to increase the dose once it was proven to be safe and only in case it was not effective enough. And that led to the observations that were described later in different papers, where the median dose, and then something interesting occurs, because many pediatricians, they would describe the dose not like 25 milligrams or 10 milligrams or these practical tablets amounts, but they would recalculate this in milligrams per kilogram per day. And this is typically something that only pediatricians do. So our colleagues who are treating adults, they sometimes are a little bit frustrated by our way of doing this, because they do not like these milligrams per kilogram per day expressions. But for the children, of course, we started very low, and sometimes with half a tablet. So we divided the 10 milligram tablet. So these practical approaches occurred, and that led to the experiences as published, that these doses, if you would recalculate it for very young children, that they would start rather low. And the range for all the patients was between 0.1 and 0.9 milligrams per kilogram per day. So what we would recommend to start with is written also here on the right panel of this slide. It's a really individual titration. It is something that, in particular for young children, is often performed in collaboration with the hospital pharmacist again. And once children are older or with adolescents, life becomes easier, and one may start using the 10 milligrams tablet. The next questions were dealing with the side effects, and they were asking what are the most common side effects for kids and adults. How can we minimize these side effects, like infections, skin infections, urinary tract infections, in particular on high doses? Should a patient stop using Empa if it causes low blood glucose levels? Do hypoglycemias get better over time? Hypoglycemias from Empa? Are there cases of patients being allergic, and how is that treated? How does Jardiance affect the kidneys? We have already touched upon that topic. And are there concerns about long-term use? Does Empa also cause an enlarged spleen like GCSF, or could it help to alleviate this in the patients on GCSF? About skin rashes, that probably relates also to the to the allergic or hypersensitivity reactions, and is weight gain common on Jardiance? So very different questions, again, on the balance between efficacy and safety or side effects of the treatment. And here it is important to realize that the side effects that have been mostly described for empagliflozin by the producer and also on the websites of the FDA and the EMA. These are mostly the side effects in patients with diabetes who are very often on multiple drugs, and under these circumstances, some of the severe side effects have been hypoglycemia, lactic acidosis, but there are also typical clinical symptoms of GSD1b. So it's very difficult to establish the cause once this occurs in a 1b patient who is using empagliflozin. In general, one could say that the safety profile of empagliflozin in GSD1b, but also in diabetes, seems to be superior or at least comparable to the one in diabetes. And I listed here on the right panel of the slide the common to very common side effects that have been described in diabetes. And again, you would not exactly know whether this is only caused by the empagliflozin or whether this is a coincidental finding in elderly people who are on multiple drugs and increasingly vulnerable once they are as they are aging. So there are also less common side effects that I already previously mentioned. They also relate to the kidney function and in particular to dehydration when there is loss of fluids of water and salts by for instance diarrhea, and I will come back to that point later in my presentation. Very simple answers to the last three questions are no, no, and no. There's no reason to believe that the Empa causes splenomegaly, an enlargement of the spleen. Perhaps it even helps to alleviate it because it would allow a reduction or a cessation of the Neupogen. Skin rashes are not common side effects, and weight gain is not common on Jardiance. However, you need to realize that with the empagliflozin treatment, there may be improved absorption by the intestines. So then it may be that there is a decreased need of cornstarch or a decreased need of food or formula. So the dietary assessment and monitoring in parallel to the empagliflozin treatment is really very important. So questions that I left unanswered in the category of side effects. Should patients stop using Empa if it causes low blood glucose concentrations? My personal recommendation would be to in parallel check and monitor the diet and make dietary changes based on the glycemic profile. If you calculate the amount of glucose that is excreted due to the empagliflozin, in absolute numbers, it is not extremely high, and probably it requires just a small change in timing of the medication intake compared to the diet, or a very small adaptation. So I would address it from that point of view. And do low blood sugar levels from Empa get better over time? Yeah, I would say yes. But also keep in mind, on the one hand side, the renal loss theory, but on the other hand, if you do not change the diet, and people will absorb the same amount of food in a better way than before Empa, there may also be a hyperinsulinemic or a rebound hypoglycemia reaction. So both thoughts need to be considered while starting empagliflozin. So this is not a trick that only the doctor can do. This is really something that ideally the team of healthcare providers does with dietitians and physicians together. Then we are coming to the next section, which is dealing with empagliflozin and GCSF. The questions here were, what are the main differences between Jardiance and GCSF or filgrastim for 1b? What are the benefits of Empa over GCSF? I think I've mentioned that already a little bit on my earlier slide, so we will skip that question for now. Are there guidelines to prevent neutropenia in 1b that include either Empa, GCSF, or both? Yeah, I answered here yes, but formally these are treatment recommendations that have been published. Does Empa also cause an enlarged spleen like GCSF, or could it help alleviate this in patients? Well, I answered that one already. I think it may even alleviate it because, well, mostly you can reduce or stop the GCSF. And how should patients adjust GCSF after starting Empa? Step down and how, or stop GCSF all at once? And these are, of course, very nice and important questions for families. But let's start with the question, what are the main differences between Jardiance and GCSF for 1b? And I'd like to compare it, make this comparison with an army. So what GCSF basically does is just multiplying the amount of soldiers. But if you do not equip the soldiers with the right equipment, with rifles, with bombs and tanks and planes and different types of soldiers, you will simply multiply the soldiers who do not know how to fight. That does not really sound reasonable. Whereas if you start empagliflozin, you will restore the functions of the army, and these white blood cells who are supposed to protect ourselves against invaders like bacteria, they will become better equipped. So they will strengthen the army and make them more defensive than that would happen. What would happen with simply multiplying the number of soldiers without any rifles? Then the last question in this slide on how should patients adjust GCSF after starting Empa. It's important to note that many individuals can remain sometimes severely neutropenic under empagliflozin. And in contrast, their clinical response can be very good. And there are several theories behind that, but it is an important observation that has been made in the patients also before empagliflozin, that there is not a very good relationship between the level of neutrophils and the clinically relevant outcomes. Having said that, if you have time, it is probably wise to allow the patient to react on the empagliflozin. I showed you the curve in one of the first slides, where the 1,5 Ag concentrations drop in, let's say, 10 to 14 days. So ideally, that timing is needed before considering to taper the GCSF treatment. Sometimes that is strengthened by neutrophil counts, but as I mentioned before, it's not a rule. Sometimes over time, the teams and the families learn that there are patients who can simply stop the GCSF completely. Some children or some adults may have significant dosing reductions, and some only allow it for short periods of time, for instance, when they have an infection, or only in the autumn or in the winter times. So that is, again, very individualized. Then there is a category of questions related to inflammatory bowel disease and empagliflozin. So these were all the questions. Does Empa improve symptoms of inflammatory bowel disease in 1b? Will Empa prevent IBD in patients who take it from a young age before IBD has developed? If patients are having breakthrough mouth sores and IBD symptoms, do they need a higher dose of Empa? Will taking Empa allow patients to lower cornstarch? Is there any interaction between Empa and GCSF, pentasa, vitamin E? How do they work together? What combination of treatment would you suggest? Empa alone is not enough to if Empa alone is not enough to control symptoms, do you recommend Empa with pentasa for IBD? Are there any updates on the Glycogen trials? I think we have enough evidence now that Empa can improve the symptoms of inflammatory bowel disease, so that's certainly a yes. Will Empa prevent IBD in patients who take it from a young age before IBD has developed? Yeah, probably yes. Will taking Empa allow patients to lower cornstarch doses? That's the experience that we have in our center, so I would also answer that one with a yes. So what if the treatment is suboptimal? So these questions also relate with, is there a place for additional treatment? And in our recommendation paper, we have not been very explicit on how the next steps should be. But I can imagine that if the treatment is not effective enough, the first steps, of course, are to check for compliance and whether the drug is doing what it is supposed to do, causing glucosuria throughout the day. So that is easily to check for. And after that, there's still a subgroup of patients who needs additional treatment. And then it really depends on what is the major problem. If there are additional IBD complaints, then probably pentasa would be the next step to take. And that's probably more rational than GCSF. But if there would be a need of acute treatment, for instance, to treat infections or to improve wound healing after surgery, then I think there is still a role for GCSF. And coming to the last question, or at least question number 38, are there any updates on the Glycogen trials? I think there are nice updates published recently. I would like to highlight this paper by the group of Maria Veda Cunha, who shed light on what can cause the differences in treatment reactions after empagliflozin. And this is very fascinating and may explain why some patients do better on the empagliflozin than others. And that is not related to the glycogen storage disease itself or the mutations that are found in the transporter, but it is more related to common variants in another transporter that is functional in the kidneys. And another paper that I would like to mention that I also mentioned earlier is from our group, in which we described very recently the repurposing of SGLT2 inhibitors for another glycogen storage disease, the so-called Fanconi-Bickel syndrome. And I find it really fascinating that we now have two ultra-rare glycogen storage diseases for which a drug is used that is originally registered for the treatment of diabetes patients. And in both situations, it is also effective to treat the non-liver related complications. So the neutropenia and neutrophil dysfunction in GSD1b. And in this particular example, in the Fanconi-Bickel syndrome, these children need high amounts of water and salts and all types of components that they are losing because their kidneys are leaking these. And for these children, we have shown that once they started the SGLT2 inhibitor, they could completely stop the other medication as well. So again, a treatment that was cost-saving, valuable for the patients because it was easier to take a pill once a day rather than taking all these supplements that was causing a lot of abdominal pain, etc. So there are more updates to be expected. And that brings me to the end of what I prepared as answering these 38 questions. And for now, I thank you for listening or whatever you have been doing during this presentation. Thank you.
Thank you so much, Dr. Derks. That was amazing. And again, want to say that we appreciate your time. I think it's pretty noteworthy that you were able to cover 38 detailed questions from patients, providers, and caregivers from all over the world. I think it's a really great opportunity to get a lot of information to a lot of people quickly. How's your voice holding up? Do you have a few minutes for questions, or are you done?
I can do it. Yes.
Okay, great. Glad you've got some tea. Okay, well, I will, I'll try and get to a few questions then that we may not have hit on. So one question, and I know this is one that we hear a lot often in patient groups, is there a best time of the day to take Empa? Once a day, twice a day, with food, with doses? What are your recommendations on timing?
I think both from the side effect point of view, the risk of hypoglycemias, but also the glucosuria and increased urine production argument. I personally would start in the morning. It's more practical. Then you can see what is happening throughout the days. So that's what I would start with morning doses.
Okay. And what would indications look like to move to twice daily dosing?
Yeah, one of the situations that I can imagine is when, for instance, despite the changes in the diet, there is still a delicate glucose balance. So if there's still hypoglycemias, that could be a situation where perhaps twice daily dosing is better. Another reason to do this might be if one has the idea that the amount of glucosuria is not during the day and the night. It probably relates to how fast or how slow the empagliflozin is metabolized. So you will reach a peak concentration quite quickly. At least that's what we know from adult patients. We do not know exactly how empagliflozin behaves in young children. It may be really different. But these considerations may make doctors dose it twice per day instead of once per day. But for most of the indications, it is once per day. Another thing that crossed my mind is that the maximal dose is described for diabetes patients, which does not necessarily mean that should be the maximum dose for GSD1b. But up until now, we approached it first and for all from the safety perspective. So I don't think that there are many people who have tried it out at all at higher doses.
Okay, thank you. Another question that we have gotten before, and for some going into the winter in the Northern Hemisphere, this might be applicable, but have you seen or can you speak to Empa reducing other types of infections like respiratory infections, pneumonias, that sort of thing? We know that there is plenty of evidence for other infections in 1B, but what about respiratory?
I do not remember by head that we captured this in the survey that we did amongst 112 patients at that time. I can imagine that it is helpful. The difficulty is to really analyze that. So it is more based on experience that I have the impression that it is also helpful for respiratory infections, for skin lesions. But it's not that I have these data available.
Okay, thank you. Let's see, there was another question up here. 1 second, sorry. Oh, and now I can't find it. Oh, the question was about IBD treatment, in addition to what Empa seems to be treating. And I know you talked quite a bit about IBD, but in one of your earlier slides, you talked about the synergy or the synergistic effect between Empa and GCSF. I was wondering if you could expand on that some, whether in reference to IBD or neutropenia in general.
Yeah. It was something that crossed my mind in patients in whom wound healing was needed, and the patient was on empagliflozin for a while, but already stopped using GCSF. But I saw an additional improvement once GCSF was restarted again. But that opened my mind that perhaps these are not. No, it opened my mind that under certain circumstances, they really may act synergistically. So if you increase the army while also providing the right equipment, then the army really can become stronger. That's the simple explanation that I would have, and that was emphasized in these incidental findings or observations in patients who were in very specific circumstances, like wound healing in one patient, but also in situations around liver transplantation. It may be important to approach it with empagliflozin and then use GCSF right after the transplantation, for instance. So there are several circumstances where I do have the feeling that they can act synergistically, but knowing what we know now about the mechanism of empagliflozin, and knowing that in the past we have used as a first line of treatment GCSF also for the IBD, I would now think that once empagliflozin is not effective enough, I would try the traditional IBD approach in the next steps of the IBD treatment, rather than simply restarting GCSF. So I think that the indication for GCSF has narrowed really to the infections.
Okay, thank you. That brings up another question that has come up. We've been asked at Sophie's Hope more over the last few years, and I think that's because we have more reach to more patients now, and and that is post-transplant empagliflozin use. Can you speak to that?
Yeah, that's a very, very interesting question. It is very important that this information would be collected more systematically. I've seen in our center, we've only transplanted one patient with 1B who was on empagliflozin before. And after the transplant, and he still needed GCSF. So he was not completely off GCSF. Shortly after the transplantation, we were able to stop GCSF, and now he's only on empagliflozin monotherapy, and he's doing very well. And he also reduced the anti-IBD treatment.
Okay. Do you know, is there a specific, or is there any literature that's come out recently that you would point people to on this topic? I feel like it's getting asked more and more the more we, hear from patients in different parts of the world where transplant might be more common.
Do you mean liver transplantation? I'm sorry, I have to allow my dog to enter the room, otherwise he's walking through our door. So we have to be patient for a long time. There is a very nice paper from the group in Hamburg who described 2 cases with empagliflozin and GSD1b who were transplanted. And yeah, there is more literature appearing, and I have the impression that based also on the improved outcomes after transplantation and with experiences in countries where transplantation is more common, yeah, all this increased increased experiences are shedding a different light on this question whether or not to transplant. It is really a topic on its own, and in particular for 1B, very challenging because of the immune and the infectious risks. But yeah, very interesting to think about and also to inform families about.
Okay, thank you. Let's see what other questions. We're trying to keep questions general.
I see the link in the chat.
Yes.
This is exactly the paper that I was talking about.
Thank you very much for that, Dr. Labrito. In terms of taking empagliflozin with other medications, is it okay to take it with other, like in the timing of it? Is it okay to take it, if you take all of your medications in the morning at the same time? Does it need to be spread out from other medications? Any instructions in that regard?
I'm not aware of any specific instructions that need to be given here with regard to the timing or any concomitant medication. The only thing that I've probably not expressed well enough during the presentation, we all know that patients with GSD1b, once they start vomiting or they have an increase of diarrhea, that they may become hypoglycemic. If they cannot tolerate the food anymore, also their lactate can rise. But theoretically, if you're also on Empa, at least 2 additional things may happen. We know from the diabetes patients that there may be ketoacidosis and lactic acidosis, and we do not know whether this Empa is exacerbating this tendency under these circumstances. But that's something to keep in mind. And the second thing is that normally, if we have a diarrhea and or if we are vomiting, perhaps when it is very hot in summer, our kidneys are capable of keeping the water. But empagliflozin is, of course, preventing this. So there is ongoing losses which will be exacerbated under these circumstances. So I think that once children or adults with GSD1b become sick, it is wise to stop the empagliflozin for 1 or 2 gifts and to discuss this with your emergency doctor, whether you can restart again once the viral gastroenteritis or whatever is improving again.
Okay, so certain circumstances where a temporary discontinuation might be called for
Yeah.
to reduce those
Yeah.
possibilities. Are there any others, surgeries, anything like that where people might want to keep this in mind?
Yeah. So you may wonder what is the definition of major surgery and small surgery. So for major surgery, it is advised to stop empagliflozin at least 3 days before. That's at least what is mentioned for diabetes patients. There is no reason to believe why it should be different in GSDs. And under these circumstances, you can consider to temporarily restart GC7 again. So that is probably an individual risk assessment where your treating physician should also discuss with the surgeon and with the anesthesiologist how long surgery will take place and how quickly the patient is expected to recover, and also taking into account the past, of course. Yeah, but surgery is one of these other indications.
Okay, great. Thank you very much. So we are wrapping up our 90 minutes here, and I'm sure your voice is probably ready for a break. Just a few closing remarks. Obviously, Dr. Derks, we are immensely grateful for all that you do to support the 1B community, and specifically your time and expertise in coming to speak with us about Empa. Being able to answer all these questions is really remarkable, and we can't thank you enough. Thank you also for all of those who've joined. I just got a quick country count just out of curiosity, and I think we have at least 12 countries represented just in participants alone. So that would be 14 if you consider Dr. Derks and myself and our country counts. So the fact that that so many patients, caregivers, and providers have been able to attend from all over the world is really remarkable, and we certainly appreciate all of your support. Thank you to Sophie's Hope Foundation, obviously, for allowing all of this to be possible. One quick note on what's to come. These webinars are planned to be every 3 months, as long as there's interest and as long as we can convince people to come and speak with us. On December's webinar, the date is coming on that soon, but that is going to be on diet. So diet and GSD1b. We're super excited about that. It's a constant topic of conversation for the community, especially, and so we're really excited to be able to plan for our next webinar. It'll be early December on diet, and again, keep in mind we are calling for questions ahead of time. So when you start seeing all of my repetitive social media blasts and emails calling for questions and announcing webinars over and over again, let it be your cue to send in your questions. We typically need them about a month prior to the webinar so that our presenters can do what Dr. Derks has so beautifully done tonight and address them in their presentation and get hopefully as many questions answered as we can. So stay tuned for that. We always welcome your feedback. You can find all of our contact information on the Sophie's Hope Foundation website or the Cure GSD1b website. We're also on Instagram and Facebook. And yeah, we'd love to hear from you and hope we can keep making these better. So thanks everyone again. Jameis, did you want to say anything?
No, just thank you. Great job, Blair. This was the first one. Always can be a little bit tricky, so appreciate all the extra effort. And Dr. Derks, thanks for setting the bar high. That was fantastic. Really appreciate all the effort, especially coming back from, I think you were at the SIEM conference. So thank you to everybody. I know we had doctors on, we had hematologists, we had even Maria joined as well. So look forward to having the next one in December. So thanks, Blair.
Yep, and thanks to our translators also. We really appreciate you.
Forgot to.
All right, take care,
Thanks.
everyone. Bye-bye.
Thank you. Have a nice evening.
You too.